a keynote address from Dr. Fauci, as well as distinguished mayors from a variety of cities and municipalities speaking to what COVID-19 has meant in their respective jurisdictions. I'm now honored to introduce a panel of experts who are going to speak to cross-cutting issues related to COVID-19, HIV, TB, and viral hepatitis. I'll introduce them all at once, and we may have someone joining us a bit late, but I'm first honored to introduce Dr. Carlos Del Rio, who is the Executive Associate Dean at the Emory School of Medicine and Grady Health System. Greg Millett, who's the Vice President and Director of Public Policy at AMFAR. Meg Doherty, who's Director of the Global HIV, Hepatitis, and STI Programs at WHO. And also joining us for this session will be Shannon Hayter, who is Deputy Executive Director of UNAIDS for Programs. So with that, I will turn it over to Dr. Del Rio to speak to fact from fiction, confronting the COVID-19 infodemic as a public health threat. Carlos?
Thank you, Jose, and thank you for the invitation to be here, to participate in this session, and to be able to talk to you at this event. Let me see what I'm doing wrong. Can you see my slides? Can you see my slides? Over the next few minutes, I'm going to talk about the, how do we separate facts from fiction? What is this? What's going on with this pandemic and relating to information? I want to quote Michael Levitt, who was Secretary of HHS in 2007, and he said, "Everything we do before a pandemic will seem alarmist. Everything we do after a pandemic will seem inadequate. This is the dilemma we face, but it should not stop us from doing what we can to prepare." And what we can now that we're in a pandemic, right? So people can say you're doing too much, you're doing too little. And I think navigating this is one of the most complicated things during a pandemic. But the reality is, as Dr. Tedros recently said, in this pandemic, we're not just fighting an epidemic, we're also fighting an infodemic. And I think this is something that has been very unique to this pandemic, because in fact, this is the first pandemic of the social media era. And misinformation on social media is not a new problem. But what we need to be certain is that misinformation has contributed to the deaths of thousands. And sometimes combating misinformation, quite frankly, seems insurmountable. And the reality is that fake news on social media have fueled the pandemic. And for many of us, it feels like the coronavirus fake news actually spreads faster than the virus. So what are the common myths that we frequently face? And I mean, we can make a list much, much longer than this, but some of the most common ones we see is, that the virus was created as a biological weapon in China, that effective treatments already exist. And, I put there hydroxychloroquine, but many others have made it to the front line. And finally, when a vaccine is available, many people say, oh, vaccine is already available and we're just not getting it. So the reality is there's a lot of misinformation that we continuously have to be fighting. In addition to this, social media has also helped to spread racism and xenophobia. And whether it's, xenophobia against people from Asia, African Americans, Hispanics, closing of borders, limiting immigration. I mean, a lot of things have happened, and social media certainly helps amplify this and spread this. So what is the science behind this? Why do people believe and share false information related to COVID-19? Well, in this study published in Psychological Science, what the investigators conclude is that people fall for fake news when they use intuition. And it's really important that we consider accuracy that will help us spot fake news. And individuals need to remember to stop and think about whether something is true before they share it with others. And I think this is something really important. Before you click on that retweet or like button, read it again and think whether this is indeed true. We also know that older people spread fake news much faster. And in fact, it's almost like a deadly habit of older individuals. And what has happened is that a decade ago, only about 8% of Americans over 65 were in social media. And today, this figure is closer to 50%. Older users probably have less experience with centralized context, and they rapidly click on baiting titles. In fact, falsehoods are 70% more likely to be retweeted than truths by older individuals. And age is one of the strongest predictors of engagement in fake news. And what you need to do is that general trust increases with age, while the ability to spot liars decreases. So it's really interesting that as you get older, you tend to trust people more, and therefore your ability to identify fake news and liars actually decreases. And this is really bad as far as spreading of fake news. So let's just think about this statement. To me, it has been really fascinating that at a time when wearing a mask and social distancing has a profound power to slow the spread of the coronavirus, many Americans have chosen not to do this. Why has it been so hard to get people to adopt these simple measures? And I think this is a question that we as scientists really need to get deep into and really need to understand. Why has wearing a face mask been so difficult? So I want to congratulate WHO, because WHO has put a website that actually is called COVID Mythbusters. And if you go to the site, and I put a couple of them up there, hydroxychloroquine does not have clinical benefits for COVID. Masks do not cause CO2 retention. Most people, that get COVID recover, et cetera. I can go on and on. You shouldn't drink poisons. So WHO really in this website is trying to have infographics to try to decrease misinformation. So how do we separate fact from fiction? First of all, we need to make sure that the information is coming from authoritative sources. So think about who are you going to follow. Think about which information you're going to look at. It's WHO, CDC. I mean, there's some places and some sites that are really authoritative and you need to follow. Check if the information has been recently published. Trust the experts. And carefully consider news that seems designated to elicit an emotional response rather than facts. And be careful to distinguish news from opinion. Many times when you're on Twitter and other social media, people are giving their opinion and they're not giving news. So a big list, probably difficult to read, but I'm going to go over it. This is a 12-item infodemic response checklist. I think it's very important that the media provides more exposure and more airtime for medical professionals, for scientists, and for public health personnel to provide authoritative, useful, and transparent information for the public. We need to promote websites of public health organizations via search engines. It's important that we verify the accounts of public health personnel on popular social media. And so Twitter and others, we really have been trying to get them to verify the accounts of people that are trustworthy. Promote the posting of public health and medical professionals. Monitor the engagement on social media platforms to control the messaging being delivered. Establish programs that help people cope with stress and address their mental health concerns. Adopt an empathic style of communication to grab public attention and address health concerns. Promote dialogue to understand people's perceptions and the motives behind their practices. Share personal experiences on social media to combat misinformation. Direct health communication strategy towards minority populations or people with different classes, races, and ethnicities. Develop educational materials and spread and share evidence-based science to address wrong perceptions, correct behaviors, and promote healthy practices. And finally, increase investment in the research and development of health communication to explore and understand strategies and ways to target different populations. I really think there's a research agenda around health communication as to how to better improve what we do and how we communicate. In conclusion, misinformation has been a major problem in this pandemic, and it is important that we as scientists invest in strategies to understand how we can best leverage mediums such as Twitter, Facebook, Instagram, and others to ensure the correct information is shared and promoted. It is time to think about developing training programs focused on positive, culturally competent, and effective communication to the public via social media so they know when and how to access truthful information. And the scientific community should utilize social media as a way to educate, inform, and empower the public at large as to how global solidarity and collaboration based on evidence needs to happen. So we as scientists need to be involved in social media, and I would encourage you to do so. And with that, I'll end my presentation and I will hand it over to Greg Millett. Greg?
Hello. Hi, everybody. Thank you for that nice lead in, Carlos. I think that a lot of our presentations are going to definitely interdigitate with one another. Let me see if I can try and get my presentation going here. Sorry for the delay. Okay, so what I'd like to discuss today is what's taking place in terms of COVID-19 in the United States and a lot of the issues that we're seeing in terms of communities of color and COVID-19 in the US, as well as the social determinants of health. Many of you know that last year, President Trump announced an initiative to end the HIV/AIDS epidemic in the U.S. And that initiative.
Greg, can you try to do? It's not in full presentation, so we're seeing all your slides.
Let's see. Not sure what's going on here. Yeah, for some reason. Okay, let me see if I can go ahead and try that one more time again. I'm not sure why that wasn't working before. Sharing screen once again. Actually, I'm not sure what my computer is doing this morning, unfortunately. I'm sorry, everybody.
That's okay, no problem.
Yeah, we might have to just go ahead and move on to Meg for right now, and then we can come back to me and just try and figure out what's going on with my laptop.
Okay, I'm happy to take. I think Shannon was going to be speaking before me, but I'm happy to present now if you.
Actually, Shannon is on with us, so if we'll just follow the order that we had, Shannon.
I'm going to join with Greg in getting my slides up and ready to go. So I would defer to Meg going next while Greg and I both solve the same problem. Thanks.
All right, Meg, you're on.
All right, the pressure is on. Let's hope I have no share screen issues. And are you seeing that, or are you seeing all the slides?
That's perfect. That's perfect.
Great. Well, thank you very much, and I want to thank the organizers and Jose and his team for inviting WHO and myself in particular to be at this session, because it's so important to us to be able to be at these dialogues. And I just wanted to also note that when I got my title of the presentation I was to make, it really caused me a bit of time where I had to reflect and say, what do I need to say about both urban and fragility? So in this talk, I'm going through why urban, and I know you've had some introductory discussions about that already, but what does fragility mean in the context of COVID-19? And then how can we move from fragility to resilience? So this is a slide that sort of is very something you see daily, but I think it's always important to note that the numbers are going up and the intensity of the infections are continuing to be moving, and certainly in urban settings as well as rural settings. but being driven in the Americas. We're seeing resurgences in Europe and also in Southeast Asia. Whereas we were seeing what looked like was going to take off in Africa, where things are starting to calm down and they're beginning to see a bit of the light at the end of the tunnel, for example, in South Africa. But I think that sets the scene as to, it's 27 million people right now, and it will be more by the end of this pandemic. And why does urban health matter in this case? It's, as Jose was saying, by right now, 6 out of 10 people are city dwellers, and that will be up to 7 by 2050. And we know that urbanization is associated with many health risks and challenges, including disease outbreaks. And in this, the COVID, it really is the perfect storm, whereas the risks of NCDs and immobility and poor diet, physical inactivity are directly linked also to worse outcomes with COVID. So WHO is definitely following this area of work. And if you haven't gone to our website, and it's great to see that the infodemic website has been helpful, we also have a manifesto for a healthy recovery from COVID-19. And in that, it is about planning and promoting healthier behaviors and safety, building back cities or building cities that are green, and making those urban areas resilient to emergencies and disasters, having hospitals in safe areas, and health centers in places that can withstand dangers and improve, I think this is so important, prepare for community emergency response and improve disease surveillance. We're hearing so much about how we were tasked globally to prepare for the next pandemic, and yet we have failed to do so. So if we don't do it now, bad on us. This is the time that we need to do it. And this manifesto outlines what are building healthy, livable cities about. How do we make a vision for social cohesion, health equity, and having a right to health framework within our cities? So something that we'd like to see by the end of all of this work that IAPAC is doing with the city's work. I wanted to give an example of urban focus of transmission and severe COVID, and I'm using the example from where I'm living right now. And on the left-hand side, you'll see in August 1 in France, we had things fairly well under control. And now after vacations, as of September 8th, you can see all the dark areas that are being highlighted here are around the peri and urban settings. So movement of people and then the proximity, the density of people leads to this ongoing transmission and the risk of severe COVID. So what does fragility mean? And certainly I don't work in the field of fragility all the time. So practically I think of service disruptions, but there are many other definitions. And if you go to the World Bank, you can see, countries in crisis, countries that have weak health systems, countries that are, on their index of GDP very low, have a very low physician to client ratio, low number of beds to client in need ratio. And here are some examples, and you could think of them: DRC, Libya, Afghanistan, Niger, Yemen, and many others. And so why is this important? That we follow both the fragility, and in many of these settings, like in DRC, Kinshasa has, 7, 10, 12 million people all living in very informal settlements. This is a concern about a risk for transmission. And also it will be harder to do surveillance and harder to ensure that the systems continue to be strengthened as we move forward. And I'll come back to some of these examples of fragile states, but also the cities in which a lot of infectious diseases are lodged and are happening. The other fragile settings can be in places like refugee camps. And for example, this is a slide from WHO where really in the refugee camps of the Rohingyas in Cox's Bazar, they were preparing for COVID and setting up tents. And now we are seeing cases starting in this setting. Or in Ghana, where you have high urban density, but you want to continue to have RMNCH activities going on. How do they set up their systems? So all of this is being learned as we work through the potential, the COVID pandemic that we're living in right now. There's also the getting back to our topic and our population of HIV, hepatitis, TB, and STIs, there's potentially a direct effect of COVID. We've seen some evidence from South Africa where there's an increased risk. The evidence coming in from higher income countries note that this could be driven by comorbidities, age, obesity. But also in hepatitis B and C, we see increased risks with those with advanced liver cirrhosis. TB is a mixed picture, but we need to follow over time and have good systems to be able to monitor death better than we do. And what we're seeing in STIs is a decline in STIs, likely because people are not coming to services, not because people are not having sex during the COVID pandemic. So there may be a resurgence later that we have to be aware of. And in pediatrics, pardon me, and we have also looked at the indirect effects on service delivery and what could happen if we have a worst case scenario. Many groups, including WHO, UNAIDS, and others have done modeling. So what happens if we have a disruption of 20% or disruption of 100% of antiretrovirals? In sub-Saharan Africa, it could take us back to the deaths that we were seeing in 2012, having more than 500 XX deaths in the worst case. Same for tuberculosis, same for hepatitis. And similarly, same for pediatrics. We often don't think about this, but if we don't have women attending ANC and PMNC clinics, we will have a rise in our pediatric cases. And this is a place in pediatric HIV where we've been falling behind, and it's not something that we really want to have happen. And so we need to work hard to mitigate those effects as we move forward. WHO and colleagues, we've been following our ARV disruptions due to COVID, and this is a map that has been recently updated at I think the end of August, but showing countries that are having disruptions in green, in red are those with disruptions, green with no disruptions of ARV delivery or of stocks. But we know this is very fluid, and so a country could have a problem this month and next month they may not. So this is something we keep talking about and also working with our colleagues at PEPFAR, Global Fund, and others to ensure that we're supplying ARVs where there are problems. We also have been looking at, can there be disruptions in testing, viral load, and key population services? And those are the ones that we're quite worried about. Whereas for VMMC, we said it was okay if they took a pause during this time. What we have seen, and others may speak to as well, is that there has been broad adoption of a policy that we really wanted to see happen of having multi-month dispensing of antiretroviral therapy, with countries moving towards the 3 months dispensing, fewer to the 6 months dispensing. But this is a double-edged sword because there needs to be adequate stock to be able to ensure that there is stock out there. But this has then trickled down into other diseases where for opiate substitution therapy, we're seeing multi-month dispensing, as well as prophylaxis medicines, hepatitis B and hepatitis C, lesser so, but it's a great opportunity to be able to push that forward and not go backwards on some of this work that we've been trying to have in terms of policy adoption and implementation. But with that, we have to watch the stocks. And I think we have had some countries with critical problems of stocks. A few of them are now coming out of that critical period. But if we don't keep a view on it and an eye on it, we could get into trouble. And most of the problems with the stocks moving into these countries in these regions has been related to the fact that there was a lockdown of transport, not because we had problems of developing the drug or potentially with packaging the drug, but it was more about moving the drug around and then inside the country, actually moving it from depot to clinic or depot to depot. So we have to think in our ways of working back better, both for urban and rural settings. How do we do this a little bit better with terms of local supplying and local distribution? This is another view of a larger survey that WHO did for its member states, but looking at broader services across 25 different kinds of services. And what you can see, partial or complete disruption was most likely happening in low and middle income countries and lesser so in the high income countries. So this is also making there's a disparity now in terms of ability to maintain those critical services, which is a fragility in the system. We also saw that the NCD services, as well as communicable, but in particular NCD services were attacked in terms of not being able to function fully. Some of the most important services like family planning, contraception, and antenatal care on this very busy slide were most affected. Whereas TB and HIV and ARV delivery service seemed to be maintained because there was a sense that these are so critical, we can't stop now. So in some ways, we've prepared well in terms of being stronger in face of a pandemic for these services. And that might speak well to the discussion that Shannon will bring up in terms of how COVID can learn from the HIV experience. In terms of NCDs in particular, you can see those services that are dealing with the highest risk factors for COVID, hypertension, diabetes, and asthma, were affected and greatly affected across the world. So it's something we have to do better in terms of chronic services for NCDs as we move forward. Lastly, we're trying to get a better view on how does this change over time. And with UNAIDS, WHO, and UNICEF, here are just some very preliminary results from a survey where we're looking over time and what is affected most. And in 30 countries, we have many more who need to report in. So take this as a grain of salt. It may change in 2 months' time. But we've had sustained decreases in HIV testing. Although the positivity rates were largely stable, we know that testing is not happening. And in some places, self-testing kits declined, whereas there was a rebound in some countries afterwards to get the self-testing kits up and running. One silver lining might be when we look at the 30 countries reporting, almost all of them maintained the same level of number of people on treatment. But what's happening is new people are not going on to treatment, and the longer this goes, there may be starting to have a fall off of people who are falling out of the system. And this is confirmed by those reporting in from the community and community surveys from GMP Plus as well. I wanted to just show a fragile country which has HIV in an urban setting, and this just came in today where it's an excellent example of what's happening in Afghanistan, where across the services, harm reduction was continuing, ART continuing, facility-based testing continuing, but no viral load, no PMTCT, and certainly no testing for key populations or partial disruptions. And overall, what does this mean? That you have a drop in the number of tests being done, you have a drop in the number of new people being put on therapy, and the overall viral load suppression is decreased. And what we've heard anecdotally that we need to follow as we move forward is some of the viral load testing and EID testing disruptions may be related to the urgency to scale up COVID nucleic acid testing, but we need to be able to do both of these together as we move forward. So in my final few minutes, I'm going to speak about how do we move from fragility to resilience. I'm going to give some examples of the essential health services and building back better. So this is a busy slide, but I like it because the red line shows us the pandemic curve. So we have our first wave, our second wave, and for the essential health services in blue, we have a temporary crowding out of those essential health services, or things are closed down, people are afraid, there's no PPE, there's healthcare workers are affected and dying, and so those services are closed down. But now in the second 6 months to the 2 years that will come now, we have to have a rebound. There's going to be an accumulated demand for increasing those services. We have to both have a catch-up plan, but continue that and ensure that as this goes over time, there may be even more increased risks or on the services and the stability of services because of the economic crises that's taking place now. So from WHO's perspective, we have put out guidance under this maintenance of essential health services. And in there are very specific sections in part 2, which speaks to HIV, hepatitis, TB. What are the services that need to be maintained? What could be paused? And here are some examples of some real innovations that countries have done. Here from Vietnam, they're using self-testing and really going more towards a self-care mode. And I think this is so important that as we move forward, HIV can help other diseases with using that self-care mode. So self-testing taking off in Vietnam. DSD, or differentiated models of care, multi-month distribution of ARVs, but also OST, DAAs, and comorbidity treatments are happening all throughout. And I believe this is a Pakistan example, and this needs to continue. We have pediatrics, where the policies for multi-months were falling behind. Now there's a report coming out where more countries are picking up this policy. And we have to do this in our way of moving forward to deliver care more readily closer to the home. For Zendari, for adolescents, they have a CATS model that had an in-clinic, outside of clinic modality. They have moved now to virtual, to using text messaging for support, to do virtual case management, and doing refills in the community. And I think also this is now community viral load monitoring is happening, as well as looking for supporting second line cases and moving on to new ARVs, but having that only when necessary that somebody goes to the centralized setting. And they've already started their own echo hub, meaning using Zoom so they can all talk to each other. So these are the things we need to do as we move forward. PrEP and PEP are doing very similar things, bringing it to the community, making sure that all healthcare workers feel safe. And this isn't a very complicated slide, but I like it because it shows how in South Africa, you can have good IPC, you can have good zoning and triaging for mobile clinics and for community clinics, and do the services, but outside of the facilities and reducing risk of transmission of COVID. Again, we need to keep aware that we have mental health and other GBV issues that can be handled virtually as well. And this is one example I really love, where you can have self-sampling now for STIs. And there was a great take-up of this in South Africa. And for hepatitis, we've been working on microelimination that has been in urban setting, in rural settings, but now we're hoping to bring it to an urban setting. So finishing up, these are images from WHO working in the COVID response, but from both Pakistan and Thailand. So urban COVID responses need urban solutions. And I think we'll hear later that HIV, hepatitis, and other services can really be used as a springboard or a place on which one can start. And overall, these resilient responses have had strong community engagement, and there needs to be subnational planning and governance. So with that, we need to build back better, and we also need to think about building back healthier cities. So thank you very much. I appreciate taking the time to listen to this presentation. Thank you.
Thank you very much, Meg. I'm wondering if, Greg, you're ready for your presentation. If not, maybe Shannon?
Yes, I am.
Excellent. Greg, the floor is yours.
Okay. Great. Can everybody see my presentation?
Yes.
Terrific. Great. So I'm going to discuss communities of color, COVID-19, and social determinants of health. And a lot of this actually interdigitates really nicely with what Meg had just spoken about. As I was saying before, President Trump announced the plan to end the HIV epidemic in February of 2019 that involves scaling up HIV testing as well as other prevention and care modalities, and then focusing on communities at highest risk for HIV. Unfortunately, 11 months into the plan to end HIV, we had the first case of SARS-CoV-2 in the United States. And for this presentation, I was going to talk about how that has been impacting HIV services in the United States. But before I get to that, there's really a lot to discuss in terms of the impact of COVID-19 in communities of color in the US. At the very beginning of the epidemic, there was some indications in a few different localities that there were higher rates of COVID-19 in communities of color. But as late as April 15th, there were 78% of the data that were missing in terms of COVID-19 by race and ethnicity at the federal level. So my colleagues and I pulled together an analysis, working with colleagues at Emory and other universities, to take a look at those counties that were disproportionately African American, using the national average of about 13% or more greater. And we found that there were 91% of counties in the US that were disproportionately African American were located in the southern US. And we found that those counties only represented 22% of counties in the US, but they accounted for 52% of COVID cases and 58% of COVID deaths. And as you have an increase of African American residents, there was an increase in COVID-19 cases. One thing that was interesting, though, that we found is that underlying health conditions did not explain the disparities that we were seeing. So even though many of these counties had lower, various underlying health conditions that are associated with COVID-19, the main explanations for COVID-19 diagnoses, greater diagnoses in those counties, was less access to healthcare. It was the number of people who were sharing housing, and it was also higher unemployment in those counties as well. And we created an infographic as mainly a gift to take a look at these counties that are disproportionately impacted by COVID-19 among African Americans from the very beginning of the epidemic through today. And as you can see, those counties that are orange are those counties that are disproportionately African American for both cases and deaths, compared to all other counties in the United States. And as you move forward, you see that these counties still account for most of the cases and deaths in the US, and that's changed recently. This is the last time that we ran these data, but as of a month ago, even though 22% of the counties are disproportionately African American, they represent 45% of cases in the US and 51% of deaths. So we're seeing something that's taking place here that's disproportionately affecting communities of color. We published a second paper that was came out last month, taking a look at those counties that were disproportionately Latino. These are counties that are about 19% or more Latino in the United States. And we found quite a bit of heterogeneity in Latino communities across the US, where there was an increase in COVID-19 diagnoses as Latino residents increased for both the Midwest as well as the Northeast in particular. We also found that people who were multilingual, or rather monolingual Spanish speakers, if you had a high percentage of monolingual Spanish speakers in counties, that was also associated with COVID-19. Many people were wondering whether or not the results that we were seeing were driven by the fact that these are communities that tend to coalesce in urban areas. And that's not necessarily what we were seeing with our data. When we did additional analyses to take a look at urbanicity, and for those counties that are disproportionately Black or Latino in COVID-19, we saw that it didn't matter whether or not it was a large urban area or if it was a rural area, that for COVID-19 cases increased as Black residents increased across counties in the US. It was slightly different for Latino counties, where we found that those counties that were medium metro areas all the way to those counties that were in rural areas, you found higher rates of COVID-19 among Latino populations. So there are some small differences that were there, but by and large, this disproportionate impact in communities of color was taking place in different places across the US. Now, you might have heard that over the summer, the United States has had a very difficult time with the rise in COVID-19 cases that were taking place primarily in the West as well as the southern United States. And about a month and a half ago, there are some major surges that we were seeing, and it was reported in the media in Texas, California, Arizona, and Florida. And many people were attributing the fact that we were seeing those surges to what was taking place in Latino communities being at disproportionate risk for COVID-19. And those data are certainly borne out by an online dashboard that we have at AmFAR, where we're tracking COVID-19 cases according to county demographics. And you can see here, these are data from California, Florida, Texas, as well as national data. And we were looking at disproportionately Latinx counties in each one of those states or nationally versus all other counties. And you can see in California, in Florida, and Texas, as soon as we reopened the United States, that you just saw this huge increase in COVID-19 cases taking place in those counties that are disproportionately Latino. And you saw that the rise was greater than what we were seeing that was taking place with other counties. And the same thing was taking place at the national level. So it really goes to show that some of these policy decisions that we're making in terms of reopening the economy too early were disproportionately impacting communities of color in the US. And we also understood too that attitudes were changing. More Americans were beginning to understand that the COVID-19 crisis was largely falling disproportionately in communities of color. These are data from a Pew poll on the left-hand side, where they were looking at the percent of Americans who said that they're very or somewhat concerned about COVID-19 hospitalization or unknowingly spreading it to others. And you can see that between April and June, that there was an increase among Latinos as well as African Americans who are both afraid of COVID-19 hospitalization and unknowingly spreading it to others. Whereas with white Americans, you saw a decrease within that period of time, with more white Americans beginning to understand that perhaps they are less at risk for COVID-19. And to the right is a poll that was done by the Washington Post to take a look at the number of Americans or the percentage of Americans who've known someone who's died of COVID-19. And it was 13% of US adults overall. But for African Americans in that poll, a third had already known somebody who had died of COVID-19, as well as about 20% of Latino Americans compared to just 9% of white Americans. So again, showing this disproportionate impact that we're seeing within these communities, particularly in communities of color. Now, part of the reason now you're seeing this impact is because many people in communities of color happen to work in those services that are essential health services where they still had to continue going to work, where they're more likely to come into contact with the virus. We certainly found that in each one of the publications that we published on COVID-19 for African Americans as well as Latinos, and others are finding exactly the same thing. These are data from a health affairs piece that came out recently where they found that African Americans and Latinos were more likely to be essential workers. That's essentially in the histograms, those bars that are red and green as compared to white Americans. And then they looked at the percentage of households where there is at least one person who could not work remotely. And that comprised 64.5% of Latino households nationwide, 56.5% of Black households nationwide. And both of that is compared to 46% of white households nationwide. So we see that in communities of color, people are more likely to be essential workers, and that really increases their chances for getting the virus. Now, one thing that's also clear is that we knew that this was going to happen, that disproportionately impact on Black and Latino communities was going to take place, because 10 years ago we had the swine flu epidemic, and even though it was nowhere near as severe, at least domestically, with what we've seen with COVID-19, there are data from CDC showing that hospitalization rates were still higher among Black and Latino populations as well as American Indian populations compared to whites. So we knew that this type of respiratory illness would disproportionately affect white African Americans, Latinos, and other communities of color. And there are those within the scientific community who are hoping that with this COVID-19 pandemic that we will finally do something different to try and blunt these health disparities. But unfortunately, we see from the data that I've been showing and others that that's not taking place. And to really put a finer point on it, we just published a paper a couple of weeks ago where we looked at the degree to which COVID-19 is impacting white Americans. So we sort of flipped it on its head. And what we did is we took a look at all of the data across counties in the US, and we divided them by quintiles according to the proportion of white Americans. So you had counties that were 60% or less white with white residents, counties that were between 60 and 77% white Americans, counties that were 77% to 88% white Americans, 88% to 93% white, and then 93% and higher. And what you can see fairly clearly here is that it didn't matter which region of the country that you're in. When you're taking a look at those counties that are primarily white, from the green lines to the gray lines, you could see that before the economy reopened and afterwards, that they still proportionally had fewer COVID-19 cases compared to the most diverse counties that had primarily non-whites. And you can see it for every region, that the green as well as the gray line is lowest. That's where we're seeing the fewest COVID-19 cases. And some of the reasons why we're seeing that is because of specific issues that have been taking place for quite some time in the United States, structural issues such as residential segregation. Another thing that is problematic as well is that the data that we've been showing in terms of COVID-19 cases in counties, as well as the data that we're seeing overall of individual case counts for COVID-19 in African American Latino communities, is probably underreported. And it's underreported because we're not necessarily seeing COVID-19 testing sites that's being placed in Black or brown communities all across the US. And that has contributed to quite a few people in many of these communities who are getting COVID-19 and not necessarily making it into the case counts. So there's some implications for ending HIV and the president's plan to end HIV. The first is that, you know, a lot of the discourse around COVID-19 has been around the underlying conditions, health conditions that are associated with COVID-19. And these are data for, again, those counties that are disproportionately African American. And sure, we see higher rates of underlying heart disease as well as diabetes within these counties. The thing, though, that we really need to be taking a look at is on the right-hand side, where we see the high rates of poverty, unemployment, and uninsurance within these counties, because that's what's really driving some of these disparities that we're seeing more so than the underlying health conditions. Just like with HIV, where we see in African American communities that these communities engage in comparable, if not less risk than white communities, but still more likely to have HIV. And a lot of that was due to social determinants of health. So it's the same thing that's taking place right now with COVID-19. The other issue too is that it's not just a disease, it's the economic recession that's taking place right now that's falling disproportionately on African American, Latino, as well as American Indian communities. We see higher rates of unemployment among African Americans, among Latinos. We're in the process right now of going through a process where many people are going to be losing their housing for renters, and that's going to be taking place primarily among Latinos as well as African Americans as well, and that certainly has implications for their health care and their health outcomes. These are data that I showed during a plenary for AIDS 2020 from San Francisco, where they looked at a continuum of homelessness and whether or not that was associated with viral suppression and viral load. And it's very interesting. You could see that as they go from homeless individuals who are going from rent to own all the way to being homeless and outdoors, that you see that the mean viral load actually decreases as people become more and more homeless on this continuum. But at the same time, you're seeing this increase in terms of, you're starting an increase in mean viral load and then a decrease in viral suppression as people become more homeless. So we know that with this recession, as it's falling more in communities of color, if you are HIV positive, that it's very likely that we're going to see higher rates of mean viral load and less viral suppression within these communities, which might mean that we're going to see more transmission. The other thing that's complicating everything is that in the United States, a lot of people's healthcare is usually associated with the job that you have. And if we're seeing these disproportionately job losses in Black and Latino communities, and that's going to also inform their access to health insurance. Mind you, in the president's plan to end HIV, there are 7 states that are a part of that plan. And before the COVID crisis, we were already seeing higher rates of uninsurance among African Americans, whites, Asians, Latinos, Native Americans, and others in those 7 states that were part of the EHE plan. So to think that that was already taking place before COVID, right now with the financial impact and the recession, we're going to see even higher rates of uninsurance in the US, and that's going to complicate healthcare access for people living with HIV. Another issue too, and this is something that Carlos had brought up during his presentation, is some of the rhetoric and other things that are taking place that's coming from this administration. There are data that are showing that particularly the anti-immigration stance that we have that's coming from this administration is impacting access to healthcare and health-seeking care for specific populations. So this was a study that was done before the COVID-19 crisis where they were showing that those individuals who are undocumented Latinos were more likely to say that the statements that they're hearing from the president is making them feel less safe to be in the US. And about 25% of them were less likely to come to an emergency room for healthcare. Now that we have the public charge rule that is part of the US, where people who are immigrants must choose between either becoming a citizen or using healthcare or other public health services, that's going to make it even more difficult for people to access care. And we're already seeing this bear out in Latino and undocumented communities where people are not seeking care. And we're seeing this onward transmission of COVID-19. And then the other things that we're unfortunately seeing with COVID-19 as well, and Meg brought this up as well, what's taking place globally, we're seeing the same thing here domestically, that we're seeing a decrease in PrEP services. During the lockdown, these are data from Fenway Community Center. They're seeing that there's been an increased lapse in PrEP refill. They're seeing a decrease in PrEP starts, and they're also seeing fewer HIV tests that are taking place. And this is primarily among gay and bisexual men. And then I think the other concern that's also associated with this is that this pandemic is already taking place in the context of a syndemic. We already have multiple overlapping epidemics here in the United States. We have COVID-19, we have HIV, we also have the opioid epidemic. And now we're seeing an increase in opioid-related overdoses across the country, including here where I am in Washington, D.C. We know that opioid use is associated with greater rates of hepatitis C. And we also know that there's methamphetamine use, and particularly methamphetamine use where people are injecting, that's also associated with hepatitis C. And there's a recent meta-analysis that was published during AIDS 2020, where they were looking in the Americas, where they found higher rates of hepatitis C among MSM who are HIV positive compared to the general population. And what I think I'm concerned about, and many others are concerned about as well, is that as we start to see increases in STIs during the COVID-19 pandemic among MSM, that's something that was reported by Fenway, and as we see greater rates of unprotected sex in people who are not necessarily on their medications, that we're also going to see increases in other diseases as well, such as hepatitis C, as well as greater injection drug use that might be taking place. There are some silver linings, though. There's a paper that was published in JAMA just recently where they found that there was no difference in mortality by race for those individuals who had access to medical care, and particularly hospitalization services for COVID-19. And that goes right back to what we were discussing beforehand about the social determinants of health and how that could help blunt some of these racial disparities that we're seeing. And the other silver lining as well is that because of COVID-19, there are more states that are considering expanding Medicaid. Medicaid expansion was a part of the ACA, the Affordable Care Act, or also commonly called as Obamacare, which allows more low-income individuals in the US to have access to health care. And why that's important is because of Medicaid expansion, as well as ACA, we've seen these increases. These are data from CDC of people living with HIV across race or ethnicity in terms of access to health insurance. And right now we've seen these states that have been reluctant to expand Medicaid. Oklahoma, Missouri, now Mississippi potentially will be expanding Medicaid. And that might have some good implications for us in making sure that we can address both COVID-19 as well as HIV. Now, I just want to close with a quote from a perspective from an HIV survivor. This was a quote from Andrew Sullivan, who was really thinking about and remarking about not only the COVID-19 epidemic, but also the opioid epidemic, and in light of being someone who survived HIV. And his take on epidemics is that, these are things that will change us, and it must. All plagues change society and culture, reversing some trends while accelerating others. The one thing we don't know about epidemics is at some point they will end. The one thing that we don't know about them, though, is who will we be by then? And I think that that's one of the central questions for many of us, is that we just don't know who we will be by then. We don't know how far along we're going to be able to get back on to addressing HIV with the efforts that have been derailed thus far as part of COVID-19. And with that, here's my information. If there's anyone who has any questions, and to the right, you could see a link to the online dashboard that we have that's tracking race and COVID-19. And I look forward to the discussion that we have after.
Thank you very much, Greg. We'll turn now to Shannon Hayter from UNAIDS. Shannon.
Great, thank you. Trying to get my screen up. Great, can you guys see my slides?
Yes.
All right. Well, thank you. Sorry for a little bit of the delay here, and how humbling to come after these fabulous introductions. I actually want to start by thanking everybody who's in the audience today. You know, we just published a report today as UNAIDS that talks about COVID-19 and HIV, and essentially talks about how at this one moment in time when we've got these two epidemics, gosh, there's a lot to be learned, leveraged, and built forward from what we've done for HIV. And this has a lot to do with everybody in the audience right now. The lessons we've learned together, our unfinished business as an HIV response community, the infrastructure that's been strengthened, whether it is laboratory infrastructure that's being used for COVID-19 and leveraged for rapid expansion, whether it's the HIV leadership. I think in many of our countries, we're finding folks, including those on this call who are part of the HIV leadership for years, are being asked to step into national and subnational COVID leadership, city level COVID leadership. And we want to make sure that we can do that while we're still adapting and compensating with our HIV services so that we don't only respond to COVID-19 and leave HIV behind. And we really hope that what we're learning from HIV and COVID-19 together can also help us see our way to that future system for health that perhaps is more agile, more results driven, and more multi-sectoral to really take care of the needs for people. So when COVID hit, where were we at in this global HIV response? Why are services so important? And I think it's important to take a look at our end of 2019 data and realize when we look at our global 2020 fast track targets of where the world has committed to be in ending HIV as a public health threat by 2030, you know, even before COVID, the world writ large was not on track to reach our 2020 fast track targets. While we'd seen a decline globally in new HIV infections, a 23% decline, that was far short of the 75% decline that we were trying to get to for 2020. Likewise, we've seen a greater success in the decrease in AIDS death, but still not quite where we needed to be. Yet at the same time, the successes that we have seen across the world have been quite variable, and we have some true successes. Many of these successes have been driven by urban areas and by cities who have really moved faster than sometimes the rest of their country or the rest of their region to really get ahead of the curve for treatment services, treatment coverage, reductions in mortality, and also reductions in new infections. This shows a variety of the treatment cascade responses over some major cities. And on the right, you see just again, going beyond city to sub-national but district level, the rate of new infections varies tremendously, with the darker color being the higher rate of new infections. So it really is important that this local agility, local response matters. And we've seen some true successes prior to COVID. Yet, as Meg already mentioned, when COVID came up, we said, not only what does this mean for people here and now in their individual or their local level, but what could it mean for our HIV response writ large? And just to reemphasize one of the findings that Meg mentioned, you know, I think about the potential costs of service interruptions, what the modeling showed could happen in terms of lives lost and new infections that weren't averted. And, you know, it is remarkable to me that in what I hope would be a worst case scenario that we won't see, but 6 months of interruption of HIV treatment services for sub-Saharan Africa alone, for example, would double the number of deaths in 1 year alone, going up to 1 million deaths. And essentially, we would lose 1 decade of progress in deaths in just 1 year, taking us back to 2008 levels. So this has been really helpful to emphasize to a lot of policymakers that we can't afford just to put the HIV response on hold. We can't afford to learn from the HIV response and leverage some of the infrastructure and experts without doing additional things to keep the HIV response going. And I think uniquely, we're also at this very unique time in the HIV response worldwide. This year for UNAIDS, we are at the tail end of what has been a nearly 2-year target setting process that will help define, okay, where do we need to be in 2025 to get to this global goal of 2030, ending HIV as a public health threat. And we're also in the middle of the next strategy development for what does that mean that countries need to commit to and to do beyond 2021. And it is quite profound, I think, that we are both proceeding with this, but also answering scenarios. Well, where we start for 2025 is really going to depend on where we land for 2020, the end of 2020. And our projections of where we thought we might land for 2020 are now probably off. And so how do we create these new scenarios? How do we really not only create the scenarios, but estimate and plan out, okay, how do we recover? How could we recover from COVID-19 based on where we land? How could we invest in a rapid recovery that makes up for lost ground and gets us not just back on track, but ahead of the game? And I think it's important for all of us to be part of these conversations. And here are the websites that sort of list some of the work that's been done and some of the processes for input, because I've heard a lot during this time about a little bit of a futility approach. Shouldn't we just lower our expectations? Maybe we should throw these long-term commitments, 2030 commitments for HIV just out the door until we're done with COVID-19. And I sort of, hope that as a community together, seeing all the work people in the audience have been doing to continue services to their clients, I hope that we can provide the evidence, the will, and the how to really say, you know what, we can do better and we can do it in a different way, but we have to pull together to get that done. So in terms of, service continuation, I think early on in the COVID epidemic, we all knew that continuity of services was going to be a challenge. But one place we started was by asking networks of people living with HIV, networks of key populations, what are your most pressing concerns right now? Is it information for COVID? Is it PPE for COVID? Is it your HIV treatment services? Is it your harm reduction services? Is it mental health services? Is it other social and economic responses? And I think across the board, across countries, across regions, we definitely got #1 concerns being continuation of my core HIV services, amongst many other things as well. And what we've seen in the response, I think, is truly remarkable. We've seen that service continuation, one size isn't going to fit all. We need agility, we need permissive policies that are actually implemented, and we need our communities in the lead. So this is just a rapid assessment from our UNAID countries offices of March to June, so early in the response, that said, okay, especially for services for key populations, so treatment services, but also harm reduction, also prevention, what are you seeing in terms of service disruption? And I think the pink or the peach color here on the right-hand side, that shows where there was reported service disruptions. The dark peach reflects where, in some cases, service had been reported as getting better, which piqued our curiosity. When we looked in a different way, we saw that service interruptions and service continuation were different for different services. And I think Meg did a good job of differentiating the importance of some of this. Okay, maybe VMMC can be put on hold. We still don't want to, you know, fail to initiate people newly on ARV treatment if we can. And we, I hope, want to do everything we can to minimize loss to follow-up of people currently on treatment during this time. And so this graph here really shows what was observed in a number of countries, 11 countries, where you see first a decline in new starts on HIV treatment, but then you see some things promising towards the end, where treatment initiations start to pick up again. And when we start digging into the pickup of these services, the recovery of these services, we find that it really has to do with agility, differentiation, innovation. As Meg mentioned, models that start to put more control in the hands of clients themselves, self-care models, taking many practices that had informed WHO treatment guidelines and service guidelines and policy recommendations to implementation at scale in ways that they maybe hadn't been in a number of countries. These are the kinds of motions and actions we started to see. And in fact, multi-month dispensing and differentiated service delivery looked pretty good on paper at the beginning of the epidemic. Those countries that had policies for 3-month or 6-month multi-month dispensing. But when we dug in, we found out there were a number of countries, many countries, who had never implemented this to scale. And so a lot of our work over the time has been working with many of you in the audience, many community organizations, many facilities, to really urge a rapid adoption and rollout of multi-month dispensing and other community distribution and other differentiated service delivery options. And part of what this gave us the opportunity to emphasize is this is good for now in terms of reducing the burden on the healthcare system, but it's also good for the future in terms of empowering clients and continuing to reduce the burden on health facilities for people who maybe don't need to visit facilities to maintain their health as frequently. Often when we started talking about multi-month dispensing and differentiated service delivery, certainly a core concern that came up is, what about the supply chain? What about the supply chain for HIV treatment medications, but also, frankly, for many of the other HIV and other related commodities as well? And I do believe there's been a strong working together between UNAIDS, WHO, UNICEF, Global Fund, PEPFAR, many of the groups that are very concerned with at the global level of procuring and delivering commodities, to have a rapid assessment and response system, to have different problem solving in place to get medicines out of a country if there was a travel lockdown and into the country they need to be. But this is imperfect, and I think as we have our prolonged state, we're going to have to see ongoing continued problem solving on this. We've certainly seen the challenges to transport, the challenges to logistics and manufacturing, but we have seen the solutions that go along with it. And together we need to continue to really bridge the gap here. But more often than not, the solutions that have really led to the sustain or the recovery of services have been community-led solutions, involving both the knowledge of the community as service deliverers, and strong links to the facility-based systems. I don't think that surprises any of us that are on this call, but I think what has been remarkable is both the rate, but also the strength with which community-led organizations have responded. We've just gotten some new data in, and we're still processing it, so it will probably be released in a couple of weeks. But we actually did a survey of many of our strong community-led organizations at country level and at regional level, and we find so many of them are absolutely participating both in the sustainability of HIV services for their community and also in the national COVID-19 response. Yet we're also seeing most of them are doing it with very few additional resources as community-led organizations. And I think folks in the audience can resonate with the long hours, the high stress, and the continued desire to serve your population. I'm going to add a few more examples to the examples that Meg offered in terms of, you know, where we have seen these sort of really creative community-led solutions, because they are heartening, they're replicable, and they're also just a few of the examples of the many diverse responses that are happening. Here is an example from Lusaka that I thought was important for a number of reasons. This is the Phenomenal Positive Youth Network, who has stepped up even further during the COVID-19 response to really provide messages and supports, not just for COVID-19, not just for HIV, but also reproductive health, also rights, working between facilities and the community to people who need this. And very importantly, in my mind, this includes a very strong mental health component, peer-to-peer supports, and also linkage to other services. And I bring that up because I believe both from the surveys we did through networks who have flagged that mental health is an issue, but also that we might not be coming out of that need in the short term. There's a lot of uncertainty that we're still caught in for the COVID-19 response, and I think we know this is going to be a protracted time. So kudos to Phenomenal Positive Youth for really making that a core part of what they're delivering during this COVID-19 time. Likewise, in Nigeria, there's been a strong step up by many strong HIV-related organizations, the Network of Women Living with HIV, both to ensure continuity of services, but also to contribute to some of the broader COVID-19 response, including community outreach, contact tracing, and response. And then finally, not a surprising example, but it was a good one. In Manila, Philippines, a project called Love on Wheels, which is really using the bikes to bridge that distance to the facility and make sure that folks have access to what they need during this time. I would point out that many of these examples really rely on, even during lockdown, community-led organizations being recognized as essential service providers. Where we have seen a clampdown on agility and a difficulty in really taking interventions to scale is where there have been restrictions on community-led organizations who have not been seen as a formal part of the response system. And then finally, to touch on, you know, we know that HIV has always been about more than just health services, and we certainly are seeing that with COVID-19. And I think a lot of the data that Greg presented about health disparities and the structural complications that are leading to, or the structural complications and the ongoing inequalities that are leading to disparate health situations for people have played out around the world. Certainly we know urban settings and city settings have been epicenters of COVID-19, but many of the inequalities and vulnerabilities that cross over in urban settings and with HIV have played out to be very important. We have seen, beyond the health sector directly, we have seen an increase in gender-based violence across many countries and many communities. We've also seen some problems with human rights. I think we know from the HIV response that the only truly effective public health response that keeps people from going into hiding is a rights-based response. We also know from our own history that when there is an unknown threat, a new public health problem, oftentimes the knee-jerk or immediate reactions can be reactions that really do bad things for human rights. We know you can have public health restrictions, including restrictions on travel and movement, that are still rights-based, that they're evidence-based, they're time-limited, they're subject to review, and they provide flexibility for those most vulnerable so that they're not further marginalized. We put out some guidance from HIV on rights in the time of COVID-19 based on our lessons early in the epidemic, and we've recently released a report that looks at 16 countries in 2 regions, in Africa and Latin America and the Caribbean, that says in the early days of the COVID-19 response, what have we seen in terms of good and bad rights-based practices to the public health response? And then finally, we are seeing people's needs for social and economic supports, for anti-stigma and discrimination, and for education, how to educate their kids and how to educate on health issues, continue to grow during the COVID-19 responses. We've called on governments to strengthen their social protection in response to COVID-19, and I think we have seen strong commitments by leaders. The Secretary General called for an immediate social and economic response to COVID-19, but we've also seen challenges in this playing out at ground level, of being resourced adequately, comprehensively enough, and at first. And so we have put out a number of tools to try to support people living with HIV and vulnerable to HIV to survive and thrive during COVID-19. And we also want to sort of emphasize that money matters. It has been heartening to see some very strong responses based on global solidarity and shared responsibility. Global Fund, World Bank, the G20, the UN Secretary General, and other bilateral donors have definitely made monies available to program and reprogram for both COVID-19 and flexibilities. Again, some of these mechanisms don't include mechanisms to reach community-led organizations for the work that they do. And so I think as we go forward to improve, these are some of the questions we're looking at, because we know if we want service continuation and recovery, we've got to include the communities and we've got to build that trust and resiliency. And so I think just in conclusion to say thank you for all the work people are doing, and we look forward to hearing about your innovations, and we're going to learn more as we go on. While we may be seeing further gaps in our overall response to HIV during COVID-19, we also must really look at how can we push and invest in a rapid recovery and even acceleration as we move forward. Innovations and services that have been stood up and implemented during COVID-19, we need to maintain many of those innovations, from task shifting to community-based service delivery after COVID-19, and also evaluate if there are any gaps in what's working with them, if there are things that we need to strengthen, improve the quality on, and move forward. But most importantly, I think we're always going to look to the cities for much of this agile and transformative health response, both in the moment now, but also in how it redefines our future together. The future system for health that's agile, results-based, multi-sectoral, and frankly, addresses these inequalities moving forward so that we're not caught yet again with something new that we don't fully understand, that perhaps we respond in ways that worsen inequalities instead of lessening them. So thank you.
Thank you very much, Shannon. And thank you to all of our panelists for what I knew would be excellent presentations. Regrettably, Carlos had to leave us. Those of you who watch CNN know that he is very popular, and as Dr. Fauci is a voice of reason and unvarnished truth about COVID-19, so we regrettably do not have him for the panel discussion portion of this session. But I'm going to start with a couple of questions, and then we do have questions from delegates that I'd like to get to. Too often we talk to each other amongst panels and don't allow for Q&A from audience. We're going to change that here. So I guess my first question is to Meg, and that is, you know, we've been speaking a lot about HIV, but and you've addressed essential services and TB and HCV, which are within your remit, but certainly hepatitis and HIV. But I'm wondering, you know, what is the level of disruption we're seeing in relation to both TB and viral hepatitis, specifically HBV and HCV? And what does that mean for getting to the TB 90-90-90 targets and the elimination targets for viral hepatitis?
Well, thank you for that question. And embedded in that, one of those very busy slides that I showed, which is based on a survey of disrupted services in more than 100 countries around the globe. We do see that TB case detection and treatment on that survey, 42% of those who were responding were saying that it was partially disrupted. But the TB community, including Stop TB and our TB department, have done a much deeper dive into those, you know, higher level indicators. And I think we're seeing the same challenges, that TB testing has been reduced, delayed, stopped in many places, and certainly in a place like South Africa, where, you know, you could really go out and doing, they were even considering and now starting to do, I believe, when they're doing testing for COVID, considering adding in the TB testing. So that's declined, as well as the treatment. So I think there's a great concern that TB will have a major rebound, such as what we're thinking about and modeling, and very similar models that have come out in terms of those rebounds that could, in terms of new cases, in terms of deaths, that could occur without adequate follow-up. For hepatitis, the kinds of data that we're seeing have been more that some of the, you know, hepatitis has not got the same sort of foothold as HIV and TB as a public health program. So most of the testing for hepatitis C in the world globally is less than 50%, even in those countries that are doing well, less than 50% know their status. So the majority of countries, it's maybe 10% of those living with hepatitis C and B know their status. And so in many ways, what we've seen in the countries who've been the forward-leaning countries around hepatitis, say Pakistan, Georgia, Mongolia, certainly Egypt, is they had several months of sort of declines, and they're getting back and starting to really restart their services. But we have to do a lot more for hepatitis, because this is the one disease where we have a treatment. In 8 to 12 weeks, we can cure this, and we're still working with very, very low rates of knowledge and very low amounts of testing. And certainly it's going to be it has and could be possibly deprioritized during this time. So I think across the board, many of the infectious diseases are seeing these challenges. Happy to get the data from the Stop TB and our WHO TB department and send them forward to your readers. Thank you.
Thank you, Meg. Shannon, I'm going to turn to you and really speak to one of the innovations that has been implemented to help address continuity of ART, and that is multi-month prescribing of ART. We've been hearing reports about stockouts, certainly issues related to getting drug from India to a variety of other countries. Can you speak to that, and, you know, any steps that are being taken to try to mitigate those stockouts?
Yeah, absolutely. And I think, you know, just to say up front, you know, we're in such close partnership with WHO on all of this, as well as in the two of us bringing in UNICEF, who has a huge role in procurement, Global Fund and PEPFAR have huge roles in procurement, as well as other players who have roles in implementation. Yes, you know, multi-month dispensing has upsides and also challenges implementing in the short term. It's not going to be unidirectional, which is why the monitoring of what's really going on now in real time as we go forward remains so important. You know, we do know that countries that were already at a high rate of multi-month dispensing before COVID seemed to have a lot fewer shocks when it came to trying to suddenly accelerate the availability. You know, it was a meeting right before we really got into main COVID time and lockdowns, where Ministry of Health of Zimbabwe, I was checking in with them, and they said 80% of their national treatment cohort already got 3 months of medications at a time or more. And they had already seen an over 30% decline in the volume of clinic visits because of that. So their health system was already less stressed. And their procurement was actually way more stable, because really when it comes down to it, it doesn't feel like this intuitively all the time, but multi-month dispensing doesn't change the amount of drugs one person needs for a year. It just changes how frequently they have to pick it up, you know? So it's still 12 person months of drugs over a year, but phasing everybody in at once, if you haven't already done it, does mean you might need this other stock and a little bit different stock projections. And so definitely there's a lot of concern about stock. We continue to work on the projections. There's a group convened by WHO that works directly with manufacturers for frequent updates on what's the manufacturing and what's also sort of the shipping challenges. We have worked to project, frankly, what could some of these interruptions in the supply chain from production to ship out mean for costs. They could increase the cost of ARVs up to 30% if they're not compensated for in different ways. But we've also seen some very creative solutions. We had a situation where the US ambassador in India made specific arrangements to get a shipment out of India and to Indonesia locally, just by calling the right people and making it through. Now, it feels weird to say, well, everything should be a one-off on that. But I think it's important to say nothing's off the table for making a plan to change. One last thing is, I think where we have seen more of a complication has to do with pediatric formulations. So we are still so far behind in treatment coverage for kids. Barely over 50% of kids living with HIV are on treatment right now. We have new and better formulations coming out, but somehow we haven't quite gotten to the production or stock security for children that we need.
Great. Thank you, Shannon. So, Greg, I'm going to turn to you. And you were referencing Andrew Sullivan and his quote about all plagues change societies. I'm just curious to know what changes do you think COVID-19 could create in both our society and our culture, and how do they overlap with the significant political and other turmoil we're experiencing, not just here in the United States, but globally as a result of oppression, racism, systemic racism, et cetera?
That's definitely the $65,000 question,
Right?
and I appreciate that. You know, I think that there's probably going to be some good and bad repercussions from COVID-19. You know, some of the good are exactly what Meg was discussing, as well as Shannon, on some of the ways that we've been doing business. That there are ways of doing business now that are qualitatively better under COVID-19 than they have in the past. I was giving a presentation yesterday to some colleagues about telehealth and prep prescriptions via telehealth, and how many more people have found that that's been much more helpful and much more successful for them. Exactly as Meg had mentioned beforehand, one of the things that I also mentioned yesterday was provision of buprenorphine. We're seeing before COVID-19, there were differences in buprenorphine prescriptions by race and ethnicity, such that Latinos and African Americans were far less likely to have access to buprenorphine for opioid substitution therapy, but more likely to have access to methadone, which is problematic because methadone, you have to go every day to a clinic. You're tethered to a place. Now that people have access to buprenorphine, we're seeing that there are more people who are getting access to, you know, these other therapies where they're not necessarily tethered to going to a place and interrupting their own work or home schedule every day. And those are all things that are good. The other thing that's good, as I mentioned in my presentation, at least domestically, is we're seeing that COVID-19 is now forcing states to revisit Medicaid expansion. There's certainly going to be an impact on states in dealing with this pandemic. None of them have planned for this, of course. There's going to be major economic implications there. And you have Medicaid expansion, which is money on the table that essentially these states have been leaving for quite some time. So now with that expansion of Medicaid, that's going to have positive implications, not only for HIV, but for the opioid epidemic, as well as for COVID-19 and some of the disparities that we're seeing. There's also some bad, unfortunately, and negative effects that we're probably going to see with COVID-19. You know, one of the negative ones is the fact that it's really exposed the lack of planning that we have in the United States. That, you know, we've had a plan for HIV. We had plans for opioids. We were supposed to have a plan for dealing with a pandemic such as this, but that fell by the wayside. And it shows just how fragile we are moving from one administration to another, that just moving to a different administration with different values and different emphases, that we were caught flat-footed. And it ended up costing us dearly in terms of, you know, the number of people who became infected and consequently died. I think one of the other issues that is probably going to be problematic as well, and both Meg as well as Shannon brought this up as well, was really the shifting of funding. We had, you know, a plan in terms of how much we were going to ask on year after year for ending the HIV epidemic in the US, how much we were going to ask for PEPFAR funding as well as for Global Fund. And a lot of that is thrown up into turmoil because we're spending so much funding right now to try and address this really poor response that we've had for COVID-19, and how that's probably going to displace funding for other issues is something that I think we all have to contend with. I think the other thing that COVID-19 has done, and this is mostly positive, I guess, is that it really has exposed a lot of these structural issues and structural racism that I, you know, talked about in my presentation, and the way that U.S. society is structured. Such that some populations are consistently at higher risk for HIV, for COVID-19, for many other diseases that we see out there. And the fact that so many Americans were at home under quarantine when the Black Lives Matter protests started taking place, when George Floyd was killed, where people could see, you know, structural racism at play and make that direct implication with how it affects disease as well in communities of color, I think has been incredibly positive. We're seeing far less of the discourse of what are these communities that are doing that are placing themselves at high risk for COVID-19, or placing themselves at high risk for police violence and incarceration, and more of an understanding of how all of these things are interrelated, and that there really needs to be a way for us to finally start addressing these issues that keep cropping up at much more of a macro level, rather than in these sort of discrete and individual buckets as we've had in the past. So there's both some good and some bad. And I really think that a lot of it is left to us in terms of the, you know, the degree to which we can tilt this more into the positive part of the arena for both global as well as domestic HIV. Oh, Jose, I think you're on mute.
God, I just can't get over this. All right, that takes me to my last question for each of you. And it's a question that I asked the mayors who participated in this morning's high-level panel, and basically is, what is your hope for our future post-COVID-19? What, similar to what I just asked Greg, what you want to see changed in relation to the various aspects of our ability to deliver quality prevention, care, and treatment services for people living with HIV, TB, viral hepatitis, and other diseases. And we'll start with Meg.
Thanks. For me, I feel we need to be thinking globally and to really embrace the concept of solidarity. That if we're not prepared for this pandemic and we move into approaches that are very isolating or nationalistic, we will continue to have these problems. And as we move forward, the issues of cities, of the challenges of migration, of people moving into cities, and then, climate change, we will have more pandemics. So this is the time to start thinking about those systems that can cross borders, that can make decision-making very transparent, and to hold potentially, governments and countries accountable if they don't step up to doing the right thing. And I think that's been the big, major challenge of the pandemic, and we can't allow that to persist as we move forward. And I get the sense that if we have our strongest and best countries leading in terms of voices, and we go that direction, I think the world would go that direction. So in many ways, that's my greatest wish. And that my greatest wish also is that all the, sort of self-care and person-centered approaches that we've taken up around infectious disease management and chronic disease management persists. As Greg was saying, we're learning so much more here. We can do a lot through the computer. Well, let's keep doing that and develop a health system, primary care, UHC, that is person-centered and really person-centered as we move forward. Thank you.
Greg?
Yeah, I completely agree with everything that Meg had said. I think the other things that I would hope that we learn from this response is that, just like with HIV, it's amazing to me the degree to which we fell into some of the same pratfalls that we had with our response to HIV, 30 some odd years later, from the ban on entering people into the country, to the stigmatization that's taking place, to the way that we even have our messaging around COVID-19 in ways that are somewhat fear-based rather than something that is more of a harm reduction approach, particularly for college students and others. And I hope that this time we finally learn from both of these experiences to really understand exactly where we veered off course and how we can course correct in time for other pandemics. I think ultimately the biggest lesson though for us, and particularly here in the United States, is the degree to which politicizing an epidemic really has dire consequences for your population. And unfortunately, that is what's taken place here. It certainly took place during the HIV pandemic as well, and part of the reason why we're slow at the very beginning in responding to HIV domestically. And I'm hoping that the next time that we're faced with a crisis of this scale, that we can finally learn from each of these pratfalls that we've made with previous pandemics.
Thank you so much. Shannon, you get the last word.
Sure, let me build on my fabulous colleagues. I was asked a couple of weeks ago about some folks that are involved with G20, like, why should we really care about sort of lessons learned from HIV? And, these are not health people, they're not HIV people, they're finance ministers and economists and private sector. And they said, Shannon, what are you going to say to me that's really going to make me care? And I said, well, a couple of things. Number one, and this builds a little bit on what Greg said, you should really think about it as fool me once, shame on you, fool me twice, shame on me. Well, we're in the fool me twice mode right now. As Greg mentioned, there are all these things that we're repeating. We're repeating unnecessarily. Now, I think we're learning a lot more quickly than we did for HIV, which is good, which is why I'm so thankful to everyone in this crowd. But still, it's a bit of a, we weren't prepared. The world was not prepared to take on this next epidemic. And the complement to that, I think, is we're also hearing a lot that we have to sort of lower our expectations. The world's going to be so poor after COVID, we have to expect that there's going to be less and less investments in health as we go forward. And my response to this non-health person was like, well, if you ever needed an example of how health equals wealth, about how failing to invest in advance in health and systems for health that are multi-sectoral, that build community trust before you need it, and that eliminate some of the inequalities that are so vast for these disparities, failure to invest in those things are what are tanking our global economies right now. So I hope that we can turn this not into a future of sort of austerity on its own, but as a future of investment in resiliency and creative infrastructures and sustained innovations that really make our life more well, more equal, and more resilient for the next time something like this comes along.
Thank you, Shannon. Well, I'm deeply grateful to the three of you, as well as Carlos, for participating in these plenary sessions. Very obviously, I also believe that were it not for the HIV infrastructure, I believe we would be in a far worse place with COVID-19. And so certainly our argument is, let's maintain the investment, but as important, be prepared for the next pandemic. You're absolutely correct. When you look at the implementation of the international health regulations, uneven implementation, or even the ability to implement across regions, it's completely uneven, and we were caught flat-footed when we should not have been. So again, thank you to all of you. I appreciate your participation. I appreciate those of you who joined us for the first day of the virtual Fast Track Cities 2020 conference. We will adjourn for the day. I encourage you to visit our exhibit booths and to access our pre-recorded sessions. There are 12 of them that are cross-cutting and provide practical information about how to deal with the COVID-19 pandemic and maintain a continuity of HIV, TB, and viral hepatitis services across the Fast Track Cities network. So thank you. We will reconvene tomorrow morning, US time, 8 a.m. Eastern time, for a series of case studies from 18 Fast Track cities around the world speaking to their experiences. Thank you. Good night.
Thank you.